Okay, so in the darkest moments of someone's life. Be the light that helps others to see. It is what gives the learning the deepest significance. A very good evening to one and all present here. We welcome you all to this INGENIUM webinar. And today's session will be on the topic Clinical Medicine in the Age of Advanced Technology by Dr. Hariharan sir. I now take the privilege of introducing Dr. Hariharan sir. Sir is the proud alumni of Chengalpet Government Medical College. He has done his MRCP from Royal College of Physicians, UK, and PGDM from George Washington University, USA. Sir is a senior consultant of internal medicine at Global Health City, Chennai, Sudhir Hospital, and few other hospitals. He is the managing director at Dr. Haran's Medicare Private Limited. He is the founder trustee of Seer Seiya Virumbu Trust, that has won various awards, including IMA President's Appreciation Award for Academics 2021 and 2022. Doctors Day Award, IMA Tambaram 2021 and 2004. Sir has presented national and international papers and conducted various workshops and has authored several medical textbooks. I welcome Dr. Hariharan sir to enlighten on today's session.
The screen share is not working now. Yeah, right now it's okay. Yeah. So good evening. Thank you for the opportunity to speak to all the young budding doctors over here. And it is a privilege to be part of Chengalpet Medical College charm because I belong to, I'm a Chemco, and by heart, it's something that is good. And thanks for those nice words. So today we'll be seeing how clinical medicine would be in the age of this advanced technology. The technology has been advancing, and I remember those days in those wards where we most of the diagnosis was most clinical, and now we work in a hospital where we have the highest and the most advanced technology. So, see, coming to technology, I think this is when most of us who were then budding to become a doctor or who had become doctor. So there was this famous person called Gary Kasparov. I think he was the world champion then in 1996 and 97. So he had to play a match with IBM created computer called Deep Blue, and he lost the match 4-2. And they had a rematch where he again lost 3.5 to 2.5. So that actually made us think, okay, there is going to be computer that is going to be much faster, much more intelligent than most of us. So let us go through certain scenarios and things and see what is in store for us. So clinical medicine has made advances as well. We have been doing the same, listening to the same murmurs, same vesicular breath sound, bronchial sounds. But then during these few years, last few decades, we have changed a lot of it. Lots of things have been changing in medicine. So one, for example, is checking of your blood glucose. I remember as a house surgeon, the most easiest way to check blood glucose was to check the urine sugars, look at the color with the Benedict's test, and then find out 1 plus 2 plus 4 plus, and then predict how much sugars were, because those times the CBG sticks were not available here in our college, and we had to deal with urine. Then came the CBG machines where we had one touch. Then those machines that were more advanced where you did not calibrate, and now you have something called a CGMS. That's a small touch, a coin-like thing that you can attach, and they keep reading the sugars every 15 minutes. And then you can just use a sensor. The sensor can be read with the machine, and you can read sugar. So this is how the technology has been advancing. And I do remember those days when if we needed help in the ward, we had to call up one landline number of an assistant. Then came the pages where you could message and they call back. Then came the mobile phones where you could talk to them directly, but then it was pretty costly. And now we are in the age of WhatsApp where we can communicate all the images, we can share videos, we can even do an echo, share it, get an opinion. So the technology has made life easy for most of us, and the advances has made it better for the patients as well. But then the concern is always, see, there are so many numerous doctors being produced in a year. Almost Tamil Nadu produces 12,000 doctors in a year. And will we be replaced by one of those machines? And will it replace the clinical medicine as such? So technology has been advancing. So artificial intelligence is being used in healthcare, where you can just ask one of those chat GPTs, you put your symptoms into it, it will give you a differential diagnosis for many. Then you have robotics, you have the Da Vinci is a big robotic surgery machine that could make your surgical life easy. The precision that you can give would make it life easy for a lot of difficult surgery. So then you have telemedicine being advanced. You can be in any part of the world, consult a doctor in most of the parts of the world, and then you can get advice regarding the same. A virtual reality is being also used in medical field, where you can train doctors. It is a treatment for some of the disorders that are there. So I think overall, the advanced technology is making impact into the medical field. And so with this, we have improved accuracy of diagnosis, more efficiency in getting the diagnosis. It helps in reducing the medical errors where things can be flagged, enhanced treatment options, and the medicine has become more personalized. And we can sit at home and even remotely monitor a patient in the ICU. And lots of benefits. So if there's a rare disease and the rare disease needs a specialist that doesn't exist in your part of the world, you can do a telemedicine consult and get in touch with the doctor. So this is how medical advances has been, the advancement has been helping in medical practice. Artificial intelligence as such has made a big impact in the field of radiology. So radiologists sit in dark rooms. They work from morning to night, seeing images that are more black and white. So they tend to fatigue. But when AI is added to these machines, the number of omissions, misdiagnosis, bias becomes much lesser. And even there are CT machines that can actually work at a low radiation, and the images can be enhanced by AI. So it is making an impact. Then there are AI-powered chatbots that lot of people used during the COVID pandemic, where to triage people, and virtual assistants for patients. They generally interact, they educate these people. For diabetes, there are stools that can interact with patients, tell them their diet, etc. So it is changing. The AI is changing clinical medicine as well. So there are the clinical value of the AI improves. There are only AI that only detect diseases. Then there are AI that can detect and quantify. And then there are devices that detect, quantify, and predict as well. So as it improves, the clinical value of these improves. There are preventive health checkups that are being done with the help of AI, and where you have scans done with low radiation. Then there are blood tests and all these things done. It is fed into a machine, and they say which is the most appropriate to treat, what is the urgency behind, and whom to meet. So there are lots of this as well. Robotics has been also helping us with the advances in medicine. So there are surgical robots, and there are application in minimally invasive procedures. As I told you, the Da Vinci machine is one of those, which is one of those advanced machines that does help us do precise surgery, difficult surgeries. Then you can see this young boy who's lying down for a physical therapy, and there's a robot next to him trying to make him impress him to do the exercise as well. Then there are robotic exoskeletons that can help people with trauma, disability move, and then there are other devices that help support as well. So robotics has been also getting into the clinical medicine aspect as such. Then coming to the telemedicine part. So telemedicine is a term that covers use of technology to deliver clinical care at very far distances. So here it ensures the person who receives healthcare when needed. When the access is very much limited, you can deliver healthcare at a very far away distance. So the use of telemedicine has been rampantly increasing post-COVID times, and it has been used in both preventive and treatment aspect as such. So when you use telemedicine, it can help people reach the underserved population, and there's a potential. For the hospitals that run, it increases the revenue to an extent. You can do preventive healthcare. You can make the healthcare more affordable, because traveling so far, so many kilometers would cost a lot to many of them. It helps the strengthening of patient relationships. So you can meet your patients over line, and they need not come to your office, and the wait time is much lesser. So patient satisfaction is much lesser. And for the patient, not traveling is a big boon, and not waiting in queues 2 hours, 3 hours to meet the doctor is another big boon. And the cost of the treatment comes much lesser. So telemedicine has made a big impact. So and there are other devices where you can remotely monitor patients for chronic diseases like diabetes as well. Virtual reality is also making an impact in clinical medicine. So virtual reality is where that is something that employs tracking and a 3D near eye display, and it gives a real feel of the virtual world. So, and the augmented reality just adds a real-time interaction, more 3D accuracy, and it makes you feel much more real. So these can be used for medical training, and it is being used for medical training, education, where there are applications where you can dissect people, learn how to dissect and learn the parts of the human body. Then this VR can be also applied for pain management, distraction therapy. So gone are the days where the Jandu Bam used to be the distraction for headaches. So there are other distraction therapies that are there. And another part which people use virtual reality is for surgical planning and practice. So those complex surgeries can be planned with VR, and you can practice surgery on these applications, and then make master yourself. So what are the challenges when we come to doing this virtual reality, the advanced technology? So the biggest challenge is, I think, in medicine, the autonomy of a patient is the one of the highest ethics that we follow. So, but these advanced technologies sometimes can lead to data loss of privacy. You can lose there's a security concern always in most of these applications, and the amount of training and education for use of this technology is much limited, a bit costly, and we need to learn to adapt to these things. So this is another challenge that has been there. And then there are some ethical consideration as well. So AI can sometimes become biased to gender, caste, creed. I mean, and when someone makes a decision with AI, the artificial intelligence, the accountability of I mean, when a doctor makes a mistake, the doctor is taken accountable. But when AI makes a mistake, we don't know who's supposed to be accountable. So there are this thing. So and then not everything is freely available on the net. So the most important knowledge is kept restricted to most of us. So that is another I mean ethical consideration that has to be there. So as of now, there's no code of conduct for the medical AI, and there can be frauds that happen when you use technology. It becomes a the data that you give into the system can become they can be sold for lots of money. The misuse of personal data can happen. So there is a lot of concern when you use all these advanced technology there. So let us go to through two stories, and at the end of this we will decide whether the advanced technology will completely replace the human brain. So let us go through this. So this was one of our college students who came to us. He was a 23-year-old person who had just finished his medical college. He had gone to Andhra to learn for his one of these London exams over there. He was sitting there reading, and then he developed high grade fever. He had some rigors. He had diarrhea on and off. He had one episode of melena that resolved, and he developed rashes over his legs and arms. And he wanted to travel back to Chennai, but his brother who was there had a broken leg, so he couldn't travel. So he was put in a train and sent to Chennai. By the time he landed in the railway station, he was actually a little bit disoriented, and they had to rescue him home. The father and mother of this child were doctors, and so the mother took this boy to the hospital where she is working, and the only tablet this guy had all through the 3 weeks was one or two paracetamol. So even in this day, sometimes it happens that people don't seek help when it is absolutely necessary. So the medical college, they had done tests, except for some thrombocytopenia. All of the tests for your dengue, malaria, scrub typhus, lepto was negative. There was a suspicion of a vegetation in the tricuspid valve. They tried to do a TE, they couldn't. They had done a blood culture, two sets of blood cultures over there, and which had not given any results. He was given IV doxycycline, some amount of azithromycin, and artesunate, which was empirical. They thought they wanted to cover down malaria as well. It was day 2, day 3 over there after admission. They were not getting a diagnosis, as well as they were not showing, there was no clinical improvement. So he was shifted to the hospital that I work in. On examination, when he arrived, he was really thin built, very poorly nourished. He was irritable. The first thing he asked me was, when am I going to die? So he was off his head. He was febrile, and he had some maculopapular rashes on his knees and his arms. Otherwise, the system examination was normal, except he had a big splenomegaly. He was conscious, but he was drowsy, but he was oriented to time, place. He was more or less irritable kind of this. So, I mean, we did something, but then just to know how what the chat GPT tells when we try to put this over there. So we fed all this information into this chat GPT because we wanted to use technology. So we asked chat GPT, what could this be? So it gave us all the differential diagnosis that included infectious disease, anything from malaria, typhoid, meningitis. It gave gastrointestinal disease like celiac disease, inflammatory bowel disease, and other infection, hematological disorders, lymphoma, and autoimmune. So it put all the differential diagnosis. So we wanted to have this is the thought that we were going. So here was someone who had fever, GI symptoms, splenomegaly, and our first diagnosis differential that we had was enteric fever. Other could be infective endocarditis, malaria, autoimmune, and the malignancy was something that we had in mind, but we were almost sure it could not be. So we did the test. The blood count was around 4,000, and the eosinophils were negative. Platelet was 1,000, 1,20,000. The kidney function was okay. There was an elevated AST and ALT, GGT and ALP were high. The proteins were low. So this is something that we had in the initial labs. So since there was eosinopenia and thrombocytopenia, which are markers of enteric fever, we thought we were dealing with someone with enteric fever, but there was something that was more confusing, that he had a suspected vegetation in the tricuspid valve. So we had been waiting. The CRP was high, ferritin, he had been inflamed. The urine was unremarkable. The peripheral smear didn't show any malarial parasite. The stool that we did a multiplex PCR, which is another advancement where you can test the stool for multiple bacteria, virus in the same sample. So it was negative. Vidal was negative. So we got the other labs as well in 2 days, where the other 3 sets of, because it was infective endocarditis, we had 3 sets done and 2 sets in the other hospital. All of them didn't grow anything. Urine culture was negative. Stool culture was negative. Multiple echoes that had been done there and here didn't show any vegetation. And CT chest showed a little fibrotic stand in the right lobe. Other than that, nothing. CT abdomen showed some mesenteric lymphadenopathy. So we were treating with ceftriaxone, and that is to cover infective endocarditis and the enteric fever. Then we put all these data again to the chat GPT. We asked, what are the possibilities there? So the chat GPT said it could be because of low platelet, it could be dengue, or it could be, although the Vidal test is negative, it could be still typhoid. And it went on to say we can consider other malarial, malaria, lepto-rickettsial infection and everything. But then it finally ended by saying a comprehensive evaluation by an infectious disease specialist is warranted to determine the exact diagnosis and initiate appropriate treatment. So this is where the chat GPT said, yes, you need some human brains to think more than what is usual when it is more than what is usual. So now the possibilities again here, when we had this, was we had ruled out malaria. Malignancy was not in our minds then. It was infective endocarditis, enteric fever, and autoimmune. So we suggested a TE, that's transesophageal echo for this guy. He was already on a ceftriaxone, so but he didn't agree for that. So this guy continuously had fever. He was not improving. So generally the dictum is, when you treat enteric fever by day 5, day 6, the fever starts to come down, but he was not getting better. So we had done serial CBCs. The platelet was getting a lower and the total count was coming down. So we had to do some other thing. He was not possible. This is happening. So we were thinking whether to do a bone marrow when this person developed another episode of melena. That's when we did a colonoscopy, and the colonoscopy showed multiple ulcers in the colon and the terminal ileum. So there was a biopsy taken and sent for culture. So this is how the blood counts dropped in spite of being treated for enteric fever. If it was an interactive session, we could have had some answers, but then this culture showed Salmonella typhi. So our diagnosis of enteric fever was right. He was continued on azithromycin. which he didn't tolerate. We had to change on to a Bactrim DS, the cotrimoxazole, and he improved and he was discharged, and now he is doing well. It is a rare case, but I mean here we I mean although enteric fever is very common, here we just try to show you how we can use Chat GPT and its limitations there. Here we will show you another use of an advanced technology that is used. So here we had a 69-year-old male who was a diabetic, hypertensive, and an asthmatic. He had severe aortic stenosis with a bicuspid valve, and he had a CABG with an aortic valve replacement and a Bentall's procedure. There was an aortic graft as well that was kept. Recently, I mean, this had happened in 2015. In April 2022, he had some chest pain. He had to gone to the same cardiologist, put in an angiograph, and he had put a stent into the right coronary artery. He was discharged. Then, following the discharge, he developed high-grade fever with altered mental status. He was admitted into the same hospital. He was treated with antibiotics. The altered mental status showed multiple lacunar infarcts, and the blood cultures showed pseudomonas. So he was treated there as a urosepsis and incidental lacunar infarct, and he was discharged. So when he came to us, he had 2 weeks of fever, and he was having high-grade fever, rigor. He had some nausea, vomiting. This was there. He looked very toxic, although his hemodynamic seems to be okay. So in short, this male who had recent cardiac intervention and recent hospitalization had come to you with a fever. So we had lots of things in mind, including the routine, your enteric fever, your malaria, everything. But since he had a cardiac procedure recently on he already had a prosthetic valve, we had infective endocarditis as the first diagnosis. Other things could be anywhere else that could still have sepsis. The source of sepsis could be there, and we could always wanted to rule out malaria and strep typhus. And the total count was around 19,000. The platelets was 1.76. The procalcitonin was high. The liver and the renal function was okay, and we had sent 2 sets of culture, and we did an echo that didn't show up any vegetation, and the valve was pretty okay. He was admitted in the ward, started with meropenem. All of the tests came negative, and we got a red flag when again a gram-negative bacteria started growing. So we wanted a cardiac evaluation. Then we asked them to repeat the echo. They were very sure they didn't see a vegetation then. So when you have someone with prosthetic valve and 2 cultures that are positive now, and there is already a culture that in the past that also grew a gram-negative bacilli, we had high suspicion of infective endocarditis. So he fitted 1 major criteria and 2 minor criteria there. So as we did this, so we asked him to go through a transesophageal echo, and for which, like most of the other patients, this person was not willing to do. So we had to prove an infection, and the ultrasound, nowhere else we could find some pus or any other lesion that could do this. So we had to go through we decided we will do something called PET scan. PET scan is a scan done generally for the oncology patients, but then it has other uses as well. Nowadays, it's being used to do for infections and other immune diseases as well. So in a normal CT scan, you just see the images, slices of images, and in the PET scan, you give radioactive material, and those radioactive material go and collect at a place where there is multiple cell, when there is a lot of cell replication, so there it lights up. So this is something done. So since we wanted to look for the heart, we had put him in a keto diet, which was supposed to be high fat diet, and we had to monitor his sugars. And by now we knew he already had Pseudomonas in blood. So this is like Pseudomonas. So we did this, and the pet showed uh, infective lesion in the near the origin of RCA, that is the right coronary, and this is how it looks on the image looks. So there's lighting up. So this didn't fit in near the valve. It was in the aortic, near the aorta where the graft was there. So it looked like a graft infection. So if there's pus anywhere, that's how what you are taught in MBBS, you are supposed to remove it. So we wanted to have a better look at it. So we did a CT angiogram, and it showed soft thickening over there, not too much of collection over there. So we had a multi-system, multidisciplinary team meeting where we sat, we decided that we will go for a conservative management, and we'll treat this patient uh, with antibiotics with routine monitoring. So this is where, I mean, the culture system that is very advanced, and then when we have PET, that's an advanced technology in medicine that helps us diagnose patients. So I mean, in this days of advanced technology, it is not nice to have someone without diagnosis and treating empirically. So the PET actually increases the chance of diagnosis from the conventional Duke's criteria. So this is the new Duke's criteria. If someone is reading for some of the exams, so you have the PET imaging is also been added to one of the as one part in the Duke's criteria. So the surgical part has been added, the imaging part is added, and the micro. So all these are major criteria. So we had two of them. This person was treated with ceftazidime, and then we had put in a long line that's called a PICC line. That's another advancement that we have, where you have a long line that is tunneled through your vein, and you can use OPD antibiotic therapy. So this is specifically for that. He had 6 weeks of it, the self-infusing pump, and he could walk around. He was at home. This patient is now on a follow. He's on a prophylaxis, and he's doing well. So this is another story where the PET has been some advanced technologies been helping us with our clinical medicine. Our clinical judgment mattered the most. We could have just treated him with antibiotics, send him home, saying that the echo was normal, but then the advanced technology helped us get to this. So in current days, there's lots of emerging technology. The genomics are there. Then you have wearables for your sugars, your blood pressures, that calculates your sleep, that calculates your activity. Then you have a potential impact of advancement like the nanotechnology and biotechnology happening. And then when you feed all these data into the computers, then you have big data analytics happening, and that helps us learn. So there are machines that help us learn clinical medicine as well in the advancing clinical medicine. So in short, so the promising future of clinical medicine with advanced technologies is helping us as well. So we need to embrace the technology. But then, as human beings, we respect our brain. So, I mean, in all these scenarios, if you didn't know how to examine, if you didn't know what to think, and if you didn't know when you are in a gray zone, which way to go, which the algorithms of the computer can't decide, I think that is something that that will say and ensure that doctors stay long. Even if technology advances, the need for doctors would always be there. Another place where I think where we will be scoring over the computer is, I'll just show you a video of something that is there. After this video, we'll break, and if at all there is a question, we will take it and then we will answer it as well. Just listen to this good music and see the video. Sorry, sir. So that is all about, I mean, see, all of us work in a place where it is highly emotional, and lots of emotions running around, despair, grief, happiness, and I think machines can't really realize one of those emotions. So I think if as doctors we are having empathy, that is listening to what our patients say, feeling what they feel, seeing what they see, and we are empathetic, we will not be replaced by those machines and those algorithms that can probably replace us in the future. That's what people think, but I strongly think clinical medicine will be there to stay forever. Thank you for the opportunity. And about the MSN, JDN and MSN network, I will tell you a few things after, if at all there are any questions that I need to answer as well. Thank you for the opportunity, guys.
Thank you so much, sir, for sharing your knowledge on integration of medicine and technology. It was a great learning, especially through various case scenarios. Thank you so much, sir.
Thank you. Can we have one or two? If are there any questions there?
Sir, until now, there has not been any questions posted yet.
Okay, I'll just be telling about something that I do very passionately as well. So, you know what Indian Medical Association is? It is the largest professional body in India, and lots of doctors are members of it. So, and we work passionately towards helping doctors, being with doctors, supporting them in their professional life and the social life. And when there are problems to doctors, I think Indian Medical Association has come to the forefront and always stood with doctors. So we invite all the young doctors to join the Indian Medical Association. So young doctors can join the Indian Medical Association just by there's a Indian Medical Student Network website where you can just log in, put in your numbers, and the membership fee for all your 5 years of being a medical student is just 500 rupees, and then you can get into us. We have lots of activities going on around, like last Sunday we had a medical boot camp of sort where we had communication skill, ACLS, BLS, and some suturing, and then lots of top people coming and talking about career opportunities. There were lectures on sports medicine, whatnot. So, and next 2 weeks down the line, we have on a Sunday, that is June 25th, we have in MGR University ECG workshop by the famous Chennappan sir. So, lots of activities for young doctors, and we welcome each one of you who's present here to join the network, because the more we are, the more stronger we are together. And if there is a difficulty, like there is problem with need, there's problem with next, a problem with future job opportunities, and as doctors, if we stay together, it is very important that we make friends, we help each other grow, and IMA is there always for each one of you. Thank you for the opportunity, guys.
Thank you, sir, for introducing about the IMA. I hope many of the students will definitely join IMA. Thank you so much, sir.
Thank you.